During today's presentation, I have a disclaimer to share with everyone in the webinar. By participating in this Altarum Institute webinar, you automatically agree to authorize recording of audio and visual content presented during this event and consent to subsequent use of the recording in the public domain by Altarum Institute. This recording may include questions and responses provided by you during the live event. This recording will be made available after the conclusion of this event as part of the Altarum Institute webinar archives and will remain available indefinitely. If you do not wish to consent to the recording, please do not join this event. If there are any questions, please contact Sylvia Romer at sylvia.romer@altarum.org. Altarum Institute webinars are intended solely to provide information to the public. The views and opinions expressed as part of these webinars do not necessarily state or reflect those of Altarum Institute. It is not intended, nor can it be relied upon, to create any rights enforceable by any party in litigation or to endorse any other organization or service. With respect to these webinars, neither Altarum Institute nor any of their employees makes any warranty, express or implied, including the warranties of merchantability and fitness for a particular purpose, or assumes any legal liability or responsibility for the accuracy, completeness, or usefulness of any information, services, products, or process disclosed, or represents that its use would not infringe privately owned rights. Today's presenter, Mr. Ronald Zumsky, APM Operations Director for Trinity Health ACO. My name is Cheryl Budimir, and I'm today's moderator. During our presentation, all participant lines will be muted. If you have any questions, please type them into the questions box in the GoToWebinar interface. Mr. Zumsky will address all questions after his presentation during our question and answer session. Due to the large number of attendees for today's webinar, he may not have time to respond to everyone's questions. If Mr. Zumsky is not able to address your questions during today's broadcast, you will receive an answer from us via email. Following today's presentation, a link to the recording and additional reference documents for Trinity Health ACO will be provided to you via email. Today, Ron will provide an overview of their organizations to include their APM structure and performance, record for quality and cost savings. He will also review time commitments, workload support, and financial incentives which accompany a partnership with Trinity Health ACO. This information provided is intended to help you determine if you would benefit from further discussions with Trinity Health ACO. We are happy to help facilitate additional meetings for you. Please note, the information presented in today's broadcast is current as of today and is only intended to be a general summary. I am pleased to introduce Mr. Zumsky, who will begin today's presentation.
Good afternoon, everyone, and thank you, Cheryl, and thank you, Altarum, for having me this afternoon. I'm certainly glad I did not have to read the disclaimer. It sounds like I have the easy part of the presentation here. So just a little bit of a bio here. As Cheryl mentioned, I'm the Director of APM Operations for Trinity Health, which means I'm in charge of about half of the Trinity Health. We have 18 clinically integrated networks spread across the country. And I'm in charge of the operations of about half of those. I have clinically integrated networks in Chicago, in Columbus, in New England, and got Fresno out in California and a handful of others across the organization. So while running the clinically integrated networks, I am also in charge of our next generation ACO, which is in its fourth performance year right now. We've got a pretty good track record out there for savings. and I'll share some of those things with you as we go through the presentation today. Probably the best way to get started, though, is to take a little walk. We got to understand a couple things before we get to discussing the meat of what a clinically integrated network and an alternative payment model are. Probably looking at the history of healthcare would be a good start. So just taking a look, I'm sure we've all seen this graph before. This is, a showing of how healthcare costs have risen over time. There's no doubt about it. There's been escalating over the years. And certainly based on this, we know we need to find better solutions to improve the health of our communities. So with this growing cost, we also know that the outcomes on the back end aren't getting all that much better. So we've got to come up with a different approach. And part of that approach is coming up with different reimbursement models or alternative payment models that will allow us to reward the development of things in processes in our healthcare system that really leads to better outcomes and overall the better health of our community as a whole. So when we started this whole process, we had a lot of focus in past years, the past 20 years, let's say maybe starting 5 years ago and going back about 20 years ago, there was always the focus on the hospital and the doctors. And that's very appropriate because a lot of care takes place there. But as the landscape here has changed, we continue to add components that, impact the healthcare services that we provide in the doctor's office or in the hospital, and making the connections between all of those things out there. So from the hospital to the rehab, to the skilled nursing, how do we roll in the social supports? How do we bring in and where do we bring in home health, and what are the impacts of our pharmacy systems and our medication products? So overall, what we're trying to get to is, as the bottom little tag there says, better health, better care at lower costs. And I'm not trying to convince anybody that all this is done out there to take care of the patient, and that's certainly the number one goal. But I think as that curve showed us in the first slide there that we looked at, we certainly need to impact cost as well. Some of the basic things I think we should take a look at is just giving some definitions. I'm going to share with you over the next couple slides a little bit on each one of these blocks here, but these are terms that we use somewhat interchangeably, but really kind of mean different things. So if we're going to be focused on one thing or another, I just kind of want to look at the definitions to them. So the first one we'll look at is the clinically integrated network. So a CIN, as we call them, is really a network of providers. It includes, for us here at Trinity, we have a large number of employed physicians, but it also includes our affiliated physicians and our partners out there within our hospitals, and again, owned hospitals and partnering hospitals and other components of the healthcare system. And under this model, we share in the accountability for the patient's care. We put the networks together here so that we can have aligned incentives, and the clinically integrated network supports through the infrastructure all the things that will make the opportunity to get those incentives and to take better care of our patients. The clinically integrated network systems infrastructures help us do that across, not only about the hospital, but going across that whole community that we have out there. So Trinity Health in its regional health ministries, again, that's what we call our, we have different clinically integrated networks in hospital systems across the country. Those are grouped into regional health ministries. So currently right now, we have about 18 clinically integrated networks out there that are focusing on care improvement for the physician practices, not only in primary care, but in all specialty types. So the clinically integrated network is really the kind of the meat and bones that we build things around. And I'm going to go into a little later in the presentation some really important components of that you as providers out there should be looking for when we talk about our clinically integrated networks. Next thing we have a conversation about is the alternative payment models. Again, we kind of use terms interchangeably here, but this is really talking about the reimbursement model that we have out there. So it's a payment methodology. It talks about the incentives that we have out there for delivering high quality care and cost efficient care. So really important that we include all the providers in there, and they have to meet the quality benchmarks, and they have to stay focused on the prevention and careful management of our chronic disease patients. As we look for the success in these alternative payment models, and there's a number of different ones I'll share with you here in a second, but as we do that, it's really talking about taking care of the patient from the beginning to the end, and really as much prevention as we can get in place is extremely important, but also taking care of the chronic patients, because they're the ones that need our focus the most and that are really our high cost drivers. So this is at least at Trinity, and I'm sure other places, we kind of categorize all of our alternative payment models out there. And as you can see from the graph here, is that in the lower left-hand corner, we have category 1. And category 1 is the typical fee-for-service model that has been in place for so long, right? You provide a service, you get a fee. In some senses, that's what led to that cost curve increasing and increasing, because as providers realized to increase their income, what they needed to do is provide more services. That payment mechanism allowed them to do that as long as it was clinically necessary and they provided that service and documented appropriately. In most instances, it was paid for. But as we rise up from going from the lower left to the upper right, that's really when the alternative payment models start taking place. And I guess you could go all the way down to category 2A, where we talk about pay per performance. That's an incentive model, so it should be included as an alternative payment model, but it's pretty lightweight. As we get up into category 3, the different tracks that we have available through Medicare, through the MSSP track 1s through track 3s, and including the bundle payment initiatives out there. These are, again, alternative payment models that are out there. In those cases, limited downside risk, but on the other hand, you have the opportunity, limited or none, I should say, but on the other hand, you have the opportunity for some upside gain sharing. And finally, when you get up into the higher categories, where we have 3 being the next gen up in the upper right-hand corner there, now we start talking about having downside risk and managing both upside gain sharing opportunities and downside risk. So certainly a different ballgame when you get up that high. And certainly we talk about, in the future, we'll talk a lot more about Medicare Advantage and the opportunities that are out there and taking full risk on a premium inside one of our clinically integrated networks. So this is really kind of that scale as we continue to build up. And for Trinity Health, I will say we have a strategic goal of getting to 75% of the care that we have across our system, we would want to have under an alternative payment model. But as you can see from this slide, we're not even close there yet, right? We have 78% of the services that we provide are paid under that fee-for-service model out there. We have a little bit in episode care, that's the bundle payment products that we're in. And then we do have some attributed lives through a number of our Medicare ACOs out there. We have a next generation ACO, we have track 3s, and we have track 1 ACOs across the country, covering a pretty good number population-wise. But those two things, which we consider to be alternative payment models, only add up to, and this slide's a little dated, we're probably at about 25%. So what we need to do in our organization, in our mind, is we need to flip this. We need to get to 75% orange and only 25% purple. That's our ideal model. And we feel that's important because we think that the alternative payment models are an opportunity for us to take care of a patient across that entire continuum and allow us to benefit through these alternative payment models. So this is the direction we think it's going to go. Our organization took a strategic stance a couple years back. Fortunately, our president, a system-wide president that just retired, I think it was even last week, came out of the CMMI Innovation Center, and he was very innovative in his views and his outlook on where we should be going with this. And he's really the driver behind this. And although he's retired as of last week, the organization, we were in a meeting yesterday, again, committed to these numbers and making sure we get to 75 as quickly as possible. Part of this is not only that we have to do our part, we also need willing our participants out there. So health plans need to be ready to share risk with us and reward us for the care that we provide, both on an outcome and a quality basis. So next term or next box that we have out there is accountable care organization. Accountable care organization. That's really the product that we have out there. And this is where a group of healthcare providers come together collectively and are accountable for the cost, the quality, and overall care of that entire population that's assigned to them. And it's completely across the continuum. So our ACOs that we have right now, we tend to use this term more often when we're talking about our Medicare products. So as I mentioned, we have a next generation ACO where we have both up and downside risk. We have several other tracks out there, several track 3s and several track 1s out there, and we're continuing to review the products that come out of CMS to see what we're going to do over the next couple of years as the products are being defined now and may change in the future. ACOs, I know, are also termed when we start talking about commercials. So you could have a commercial ACO out there. Sometimes when you're talking to employers, they're calling their product or their intent to be an ACO again. And it's relatively a loose term, but it's really talking about the accountability component of it. So the last thing I want to talk about is kind of putting it all under a big umbrella. And that's really what population health is to me. So all those things that we talked about, the development of a clinically integrated network, and we'll talk much more about that in a minute, the model that we have out there through the alternative payment models and the products that we have out there. When we look at that across the board, we call that population health. And it's really it's really aimed at improving the entire community that we're involved in. And so again, it brings us back to this picture here where the landscape has changed and population health and how we handle the patient and provide them services under this big picture, to me, is really called population health. And so that's just kind of an overview of terms and technology, or terms that we use when working with this. But now I want to take a couple minutes here and actually go through and talk about what makes up a clinically integrated network. So as you, as providers out there, are looking at becoming more and more involved in alternative payment models and looking and trying to define where you should go, it's really kind of, you can look at the model, and that's very important, but you also have to look at the infrastructure that the clinically integrated network brings, because that's what you're joining. You'll be joining a clinically integrated network, and the clinically integrated network, the SINs will have expectations of you, and you should have expectations of them. So here are, from our perspective at Trinity Health, what are the 6 core capabilities, the things that need to be within a clinically integrated network to make sure that we can improve the care and lower the costs for our ACO patients and in our alternative payment models in general. So I'm going to go through each one of these. So we got leadership and governance, we got integrated physicians, advanced care model, analytics and IT capabilities, comprehensive networks across the continuum, and then finally, payer alignment. So again, I'm going to go through each one of them so you kind of get an understanding of what each one is, and then we can kind of pull it all together in the end as we talk about payer alignment. So when looking, again, I'm trying to put my hat on as a provider out there and looking at what should be looking at. When you're talking to clinically integrated networks or your POs out there, you want to make sure that there is a good, strong leadership and governance, that there's a plan out there, a 3 to 5 year strategic plan, that they know where they're going with this and they have the vision. And not only is that vision incorporated within the clinically integrated network, but it also needs to be vision passed on to all the providers in that network. So if a clinically integrated network has this great vision, but the hospital systems that are in that network don't have that vision or don't understand that vision, it's going to be a pretty hard push. So we need to really go out there and do some education on what is population health and what are we trying to do with these alternative payment models. Because remember, part of it is we're going to be taken away from the hospital systems and the skilled nursing facilities and the home health providers, and we're going to make sure that we're using those dollars effectively to incentivize and build infrastructure and incentivize our providers out there. So make sure that all the key executive positions are filled, and that sounds like a little bit of a weird one in here. It's extremely important, because the point is that running a clinically integrated network effectively is not a part-time job. It is a lot of work, and it's a lot of visioning. It's a lot of making sure that the infrastructure there, and it is a lot about changing the mindsets of the providers out there at all levels of the setting. So probably the second most important thing is really talking about physician champions. Again, as providers out there, you know that your physicians or your providers out there are listening to those who are more like them. So physicians and or other providers that really understand what a clinically integrated network, what an alternative payment model is, and what the vision is. And if you have that voice on your board as a clinically integrated network, it's extremely important to get that feedback and understand where we're going with it. So once we have the leadership in place, the next thing is really talking about integrated physicians. And this is really, again, where you guys come in, right? We want to make sure that we have a comprehensive engagement approach so that all of our key stakeholders know what that vision is, know what their roles and responsibilities are, and know where we're taking this alternative payment model or population health that we're working in. And so that includes the primary care physicians, the specialty physicians, the care teams at the hospitals and skilled nursing facilities. So, and while the primary care physician is an important component of that, that's where the care really starts going. The specialty networks are extremely important. So we need to make sure that we have a specialty engagement strategy out of there. And from our perspective on a management of a clinically integrated network, we're always looking at our care coordination rate. And for us, that's telling us how much of our how much of our care is in our network. So, you know, if we have 50% of our care going outside of the network, our care coordination rate is 50%. If that's the case, you know, we're going to have a hard time moving the needle there, because we have a lot of physician and a lot of care being delivered out there to physicians who aren't engaged. So we're going to do our efforts to keep things within our network, and part of that is making sure that we, again, get these care coordination numbers rates so that we make sure that the specialist engagement strategy is working and we have good specialists engaged. So the other piece is, if we're going to do integrated physicians, we need to have some feedback mechanisms to them. We need to, the other way, I'm sorry, one more. So we need to have the scorecards out there to develop and make sure we're providing feedback. We can talk about this all we want, but we need to show the providers where we're at with that. And then again, just like, and again, an important component of the alternative payment model is making sure that we have incentive structures out there that will incentivize the physicians to perform in the way that is best for their patients and that is rewarding to them. And then that really leads into some gain sharing issues, which we'll talk about next, or down the road here a little bit. The advanced care model is really talking about how care is delivered within the clinically integrated network. As we saw from that, cute little picture that we had out there, we're taking care of a full continuum of care out there. So oftentimes what happens, and I'm hearing stories all the time from our clinically integrated networks, is the issues that we have during coordination between one side of care and the next. So a lot of focus on how do we move patients successfully from the hospital to the skilled nursing facilities, how do we move them from then the skilled nursing facilities to home health, and then finally to home. So I probably could share a dozen stories with you of cases that are bad. Last night I was on a quality call that incorporates all of our clinically integrated networks, and they told a great story about transitions of care of a cardiac patient who fell through the cracks and was missed on some of these transitions, and we caught up with them through looking at our data. And when we finally caught up with them and started working with them through social services and through the network, that we ended up providing a much higher level of care for this patient, and the success story was fantastic. So we need to establish a process to evaluate our partners out there. I shared with you that we have scorecards out there, and we usually use those for our physician providers, but we're always looking at the quality of services and the performance of our skilled nursing facilities and our home health agencies, and really focusing on both quality and utilization. And we set the metrics out there, and when these organizations meet those standards out there, then we get the ability to create a preferred network. And that's really where a lot of the success of the alternative payment models is seen, is working within a preferred network. So while we have 50 skilled nursing facilities here in southeastern Michigan, based on where our population are located, where they're receiving their services, we develop a preferred network around there, and we work with a handful of skilled nursing facilities in an effort to make sure that we're communicating with them properly and that the right level of care is given to those patients and they're moved to the next level of care appropriately. So we also know that in more and more it's becoming important how both the behavioral health and I should have changed this slide here. It says social determinants. That sounds like it's a little complete. It probably should say social indicators, because we think that part of the changing those social aspects of it are going to be key drivers, particularly as we get further and further along in our care. Once we're taking care of the chronically ill patients and we're getting them at the right point of care, we got to start thinking much further in front of that when we're looking at what we call our rising risk patients, and what's getting them into that rising risk categories, and what can we do with that. And oftentimes it has to do with behavioral and social issues that are out there. So a lot of focus being put on that on our clinically integrated network side. The next big component is analytics and IT. If you're looking at a clinically integrated network, thinking of joining it, you really need to make sure that they have all the data coming to them that can really help them analyze the care and take care of your patients with you. So things like eligibility list, do they have all those? Are they paid claims files all in there? I will tell you here at Trinity, we will not do an alternative payment model without getting these things in advance. That's one of the number one things that we start the conversation these are our expectations as it relates to IT capabilities, and these are the things we need to see, not on day 90, not on 120, but on day 1. And it's important that we get this information because you can't manage the patient without it. And then we really have to start talking about a communication process. Again, a lot of analytics are done, and we have a great analytics team, but if we're not sharing that out there with our network and allowing them to use the tools and the analytic capabilities we have, we're not doing a very good job. So a lot of focus on that. And then really when we're looking at our partners out there, and again, we've got a pretty broad system and IT capabilities, but there are times when we have to go outside of our own organization. Sometimes it's better to buy something than it is to build it, particularly when it relates to issues of timeliness. And so when we're talking to our IT providers out there, we're communicating the same type of information to them and making that a requirement of them as well. The comprehensive networks, this is a little different than the integrated providers that I talked about a couple slides ago. This is really looking at our network and making sure that it's efficient across the entire service area, and that we're in a position that we have really a high performing network. And again, it's part of taking a look at those scorecards and weeding out at times providers if we don't believe that they're a good partner for an alternative payment model. We occasionally have to weed out providers, but we're more likely to try to engage them and pull them in. But it's really looking at addressing provider gaps out there as well, because again, you're taking care of a population, you need to have a broad but strong network. So we look at network adequacy reports, which will tell us for this population that we're serving, we need to have this many cardiologists, and they need to be located here and here and here. Different payers have different models out there. CMS has a very defined model. We run those internally all the time, and we're looking at where we can provide opportunities for other providers to join our alternative payment models, our clinically integrated networks, based on where we find these gaps. So really is defining, trying to get a strategy to get rid of the high cost out of network specialties. Sometimes, we do that through agreements with other clinically integrated networks. I'll share with you, in my past, I've been involved in the creation of a pediatrics clinically integrated network, because those are, those types of specialties there are very focused and are very limited, and the resources are scarce out there. So accessing a clinically integrated networks on specialty pediatrics was an important component for us. Right now, we're really developing our SIN value statement that talks about why we are and what we think that we can provide through a clinically integrated network. And I got a full slide a little bit later that I'll share with you on that. So payer alignment is kind of where it comes together again. So we talk about developing a glide path. So no one can step into this. I shouldn't say no one. It's very unlikely that anyone can step into this if they're down in the lower right-hand corner of that, lower left-hand corner of that on a fee-for-service model and jump all the way up to 3A or 3B or even 4. So we need to develop a glide path of how we get these networks from point A to point B. And part of that glide is working through all those components we just saw, and then really taking a look at each market that we have out there and analyzing what the payer's looking for, what the market is giving us, and how it's changing. Again, we need to have willing partners to help us on this. And so we can't do it alone. We need to have a partner. So Part of what we do is we really kind of create what we call a pitch back, and it's part value statement, but it also talks to the payers and the employer groups out there that says that, you know, to get the best value, we're your partner, and we are that because of all those things that we just talked about, and that we have a focus on taking care of the patient and putting the clinically integrated network together in the right way. Next slide. So I think an important aspect from you guys out there as providers is really taking a look at a SIN value statement. What value do we bring to the table? And when I say we, in this case, I'm talking about clinically integrated networks in general. These are some of the next slide talks about some of the things that when we sit down and we ask ourselves how our networks are doing, how our clinically integrated networks are doing, and what's important to the providers out there. You know, these are a couple things that we think that we can provide value. So first of all, I think we need to create a framework that we can deliver better care, a better way to, you know, to provide care, and that we do that in conjunction with our patients and providers in mind. So it's really the clinically integrated networks that are putting things together. As providers and individuals out there, it's literally impossible to do it on your own. So we need to create the framework out there, and that's the value that the SIN can bring to you as providers. As we continue down this path and we continue to grow alternative payment models, I think that we have the opportunity to bring growth to your practice through the increased number of lives. As we continue to get the preferred contracts out there that are based on the superior quality and outcomes and patient experiences, those get recognized by the payers and by the employer groups out there, and they're starting to demand more and more of this. And so as lives get funneled into the clinically integrated network, your involvement of that could lead to some growth for your practice. So the other piece to it is I always hear, and again, I'll share a quick note with you that I've ran physician practices, a large physician practice group of about 120 providers out there, that they always were worried about, and I shouldn't say complaining, they were always mentioning that they're having trouble with the referral process. So a piece that the clinically integrated networks can really do for you is to get you access to, clinically specialists out there, and make sure that you have an opportunity to get the referrals out there through the networks. And I jumped all the way down to the bottom, and I apologize. But the piece in the middle there talks about access to shared savings. Again, our goal is to take really good care of the patients, have great patient satisfaction, and save dollars. When we save dollars, we have to roll those dollars out to the providers. So while you may be receiving some dollars on a fee-for-service basis in some of these alternative payment models, the real opportunity is looking at the shared savings that could come through our efforts in a clinically integrated network to lower the overall cost that's being incurred out there. So, and again, from an individual practice or even a multi-specialty practice out there, it's pretty tough to build the clinical infrastructure that's needed. There's a lot of care management opportunities. There's transition cares that we talked about, from hospital to skilled nursing to home health, and so on. To have all those components in place there and really providing you the infrastructure that you need out there is pretty tough to do on your own, but a good clinically integrated network should be delivering that to you. I mentioned again as one of the key pillars to a clinically integrated network, the data and analytics portion. That's extremely important of what your clinically integrated network should be providing you. It's great to know what happened to your patients, but the predictiveness that should be built into the analytics on a clinically integrated network level to capture high risk or rising risk patients is extremely important. It's the real opportunity to save cost is to prevent cost before it even happens through better interventions way up on the front end to a rising risk patient. So a lot of network, and again, I mentioned the referral process here. There's a lot of administrative burden that we can help with on a clinically integrated network. So that's, I think, the value statement that we bring, that we want to bring, and I think any clinically integrated network should be bringing to U.S. providers. So I think this is one of the key slides. But let me talk a little bit more about how we evaluate and how we measure our performance. I think it's important for you to kind of understand what happens in the background and how some of the things that we've been talking about, in particular in that middle of the slide previous, where we talked about access to shared savings, that's going to become a more and more important component as we go forward. So some of the things about how we measure our performance, and I will tell you that it is always a work in process or progress. It's really taking a look at what we call key drivers. What are the things that when we're looking back that we think we need to focus on in an effort to save dollars across the board? And again, just importantly, if not more importantly, putting the patient in the right care setting, making sure the patient's satisfied. All those things are important, and we measure every one of those. But these are what we consider, at least these top three here that you can see in the first three boxes or first three rows of this slide, are really the key ones that we focus on. Skilled nursing facility days, how often are our patients getting into a skilled nursing facility and how long are they staying there? Again, engagement with a preferred network of skilled nursing facilities allows our care management team to work more directly with them to make sure that we're monitoring the patient, not on day 1 and then again on day 30, but measuring their progress and understanding their care on day 1, day 2, day 3, and so on. So extremely important. Another, obviously, a large driver to care is the inpatient admissions. Again, if we're catching patients on the rising risk scale, we're going to impact the inpatient admissions. And again, remember I told you about engaging with our partners and making sure that we're educating our providers out there. Even within Trinity Health, where we have our hospitals and our clinically integrated networks under the same umbrella, we spend a lot of time talking to our presidents of our hospitals that if we're really successful at this, you're going to see your inpatient days go down. So, from their perspective, they're going, they're scrambling. But on the other hand, we make sure that they understand when those days goes down, the alternative payment model delivers the dollars through the incentive payments that could have been lost through those inpatient admissions. So a lot of focus there. And again, the ED visits are two things. One, I consider the ED the front door to the hospital now. So many patients who go through the ED end up in the hospital. So that's an important component. But the second piece is that we still, to this day, and we see it in every number that we look at, is that we still have a lot of inappropriate use of the emergency departments. While we have urgent cares and we have primary care visits with late access, and I should say great access, the patients are still going to the ED because that's a long trend that needs to be broken. And, that's, again, an area where we think that we can impact, but again, not only the cost, because there's a cost of going to the ED versus an urgent care, but more importantly, that the setting's right, the care's right, and the patient's, satisfaction level is pretty high. So then a couple other ones that you can see on the bottom there that we think are key drivers. Community-based palliative care has become a huge part of, and again, we spend a lot of our alternative payment modeling in the Medicare side of the business. So community palliative care is an important component. Same with Part B drugs. Again, I'll share with you, looking at some data over the last couple of months, we've noticed that some of the drugs that are being used for macular degeneration, are extremely expensive, and that there's alternatives out there. So again, part of a clinically integrated network is to identify them and then work with our providers out there to educate them and get those things moved over. That's literally, and again, we've got a next generation ACO that spans 4 states and counts up about 80,000 members, but that was over $1 million worth of savings there. That and the effectiveness of the alternative is just as good, if not better. So great opportunities when looking, and that's what data mining is going to find you. So again, just wanted to share with you a couple things about how we look and how we measure ourselves, and many of the things that you'll see as you go forward. So I talked a lot about the incentives that we have out there, and the part of the value of being in a clinically integrated network and working within an alternative payment model is that as we change care and we save costs, that we have an opportunity to do gain sharing within the systems. And so, the big question is, all right, now that you've saved all this money, what do you do with it? And if we're successful in shared savings, and again, at Trinity Health, we've been fortunate enough to be in that situation over the last couple of years. We've really spent a lot of time focusing on how to reward, in our cases, what we call our chapters. But I'll share with you the model here. You can see across the bottom there that we call these chapters, but these could be your physician practices out there. If this is a single, let's say a single state or a single physician organization gain sharing model. So the first thing we do is when we get shared savings, in our case here, most of it's been coming from CMS and our next gen product. We take out an administrative piece. Everybody's got administrative pieces, and we have 4 chapters out there. In this case, in 18, we had 5, but we have 5 chapters out there. So we cover everybody's expenses. And then once we do that, we develop a gain sharing pool. And then we take a look at some of what we call the key drivers to that, along with the population, attributed population for each one of those chapters. And we make a distribution and then allow them to distribute it to their physicians. So this is a pretty typical model. I've been involved in 3 or 4 ACOs. Everybody's got a little different version, but it's pretty typical. It's important that we measure, and when we talk about it here at Trinity, we look at year-over-year performance, so and improvement. So we do that, again, we do it at the chapter level. That's our 4 or 5 state regions. But again, this could be done at the practice level as well. And again, we look at, in particular, as I mentioned from that slide just previously, high emphasis on inpatient days per 1,000 and skilled nursing facility days per 1,000. And then I'll share with you a quality set that we use, because again, we can't just be cutting the dollars out and not maintaining our quality. So each of these areas have 5 points to attach to them. So if you were perfect in all these, and I'll tell you that no one is, you could get up to 15 points, and then you put that against your attributed lives, and that's how dollars are distributed. Now, share a little bit more modeling with you here. So on the inpatient, we suspect that, and we hope that our chapters out there are improving. So let's say in this case, up in the top half of the slide there on the inpatient days per 1,000, if you improve 5% over last year, then you would get 3 points in this model. And on the bottom half, if you improved 15% on your skilled nursing facility days per 1,000, if you improve 15%, you'd get another 3% or 3 points for that. So coming off this slide, let's say maybe you have 6 points. And then we take a look at the quality sets that we have out there. So we determine in advance that we're looking at a number of different quality metrics out there that we have to report to CMS. And we measure each one of our chapters, or and again, in this case, you could be talking about practices, how they did on each of these measures. And we base our scoring here based on the percentile that they reached in their quality metrics. So as you can see on that top one, Care 2 measure, their score was 80%. That put them at the 70th percentile. For the 70th percentile, you get 1.7 of those points. So if you added all 11 of them up, obviously it's 22 points. So instead of earning 2 points on that because they were at the 70th percentile, they only earned 1.7. If you look a little further down, I've got the red arrow there. In this case, they had a score of 63.4, which put them in the 60th percentile. And in that case, they earned 1.55 points for that. And in this case, if this was a practice or a chapter, out of the 22 points here, they earned 18.5, which I think ends up being something like 80-some%. And then we put that against the chart you're looking at here to see how many points they've had here. So let's just say it was 83, maybe it was 83%. They would get 3 more points from here. So they had 3 points on the inpatient, 3 points on the skilled nursing side, 3 points here, 9 points out of 15, and then we use that against your attributed lives and calculated gain sharing. So you get opportunity as you have more lives, but more importantly, even if you have more lives, if you're not doing well on these metrics, you're not going to get a large portion of your gain sharing. It will go to somebody else who's doing a better job. So I'll just share with you, out of the 5 chapters we had, the second lowest number of attributed life chapter received the highest incentive gain sharing dollars. And that was because they did such a great job on those 3 metrics that I just shared. So I think we're probably getting close to the time here, so I wanted to make sure that we left some time for questions. And I hope at least I provided you with some sense of the value of a clinically integrated network and how the alternative payment models are using those networks in an effort to really start changing how we deliver care across an entire continuum of care, and more importantly, an entire population or community of patients out there. So with that, I'll open up to questions.
Thank you, Ron. Really, truly appreciate it. Wonderful presentation. Do want to let everybody know that we will be sending out this presentation as a PDF. We will also be having a link to the total presentation on Alterum's website. We will also be sending that out as well. We have quite a few questions. We won't have time for all of them, so I do want to let everybody know that we will be sending out the questions and answers along with the presentation links. So everybody will get their questions answered. The first one is, I'm sorry, my screen's jumping around. A very specific one. We have them coming in left and right. Hold on. How about from the IT side?
Yes.
Do you have a physician dashboard that you expect your physicians to reference and respond to?
Yes, and we have that for our employed physicians. Obviously, they have a whole different set of dashboards that relates to metrics going on in our employed practices. But yes, we have dashboards that we share with our physicians. We do that through the clinically integrated networks, and we have a provider service rep that's going out and sharing that dashboard and having the conversations with the providers out there directly. Again, you need to know your numbers, and you need to know your performance from a provider end, and providing those scorecards is an important component of that. So yes.
So what is the enrollment deadline for 2019 as well as for 2020?
For
physicians joining.
Oh, physicians joining. We can add practices, and at least in our ACO, we can add practices throughout the year. Unfortunately, for primary care providers, we can add them, but they won't get attribution. until the following year. So the best time to be adding is previous to June, because what happens is in June we have to submit to CMS a list of our providers. So this past June, a couple of weeks back, we sent a list to CMS of all the primary care providers in our network, and we can take providers off that list, but we can't add providers on that list. And then it's finalized in September, and that's what becomes the base for our attributed lives in 2020. However, for specialty practices, we can add them anytime. We generally go into a hold late in the year because so many things are going on with the network and so on that we'll accumulate them, and then the first opening that we have in January in our Medicare ACOs will add those providers at that time.
What does it cost to join the ACO? There
is no cost to join the ACO. Two things, I think that's an important component, is in some, I believe in some ACOs there are some costs. Clinically integrated networks, quite honestly, there shouldn't be any cost. Trinity's line on that is that there shouldn't be any cost to join the network. What we're more worried about is not the dollars that you're going to bring to the table. We want engaged providers. So I would easily take no money from a provider who's completely engaged rather than take $500 a year from a provider who doesn't, is not engaged and is not willing to participate in or change. So the other component of understanding this is I shared with you again as we went, and I always got to grab my pencil because I'm right-handed, as we went from the lower left to the upper right on that curve, there's downside risk, and downside risk can, in many alternative payment models and clinically integrated networks, that downside risk can be passed on to the provider, so you should be very aware of that. From our perspective at Trinity Health, part of what we do is that we believe in developing strong clinically integrated networks, and because of that, we do not pass any downside risk onto the providers. So make sure if you're talking to clinically integrated networks or POs out there that there's, know what your downside risk and make sure that you can manage it.
How about behavioral health?
As I mentioned in the slide there, behavioral health is becoming more and more of a component of how we take care of our patients. Certainly many of our patients are experiencing behavioral health issues as they either one, fighting their chronic condition, or it's part of the situation that causes their acute care. So it's becoming much more of a focus. I'll be honest that we're probably not where we're at with that in our clinically integrated networks, but I will say we have two work streams going. One is on, again, not social determinants, but social indicators and behavioral health, and those are two important components of it. So we'll be driving more of that over the next 6 months or a year.
Well, excellent. We are running short on time, but there is a very specific question I did want to get a chance to ask. It says, are you open to a partner with a pediatric office who is located in Calhoun County?
And Calhoun County is located on the west side of the state? South? Oh, right in the middle. Okay. Well, I will tell you, we have in Michigan, we have two clinically integrated networks that are coming together. We have one called Affinity on West Michigan, so it's out in Muskegon, but it pulls in Grand Rapids. So we come, east from Lake Michigan, and then we have a very strong network here in southeastern Michigan, which pushes out into the west side of Washtenaw County and up into Livingston County and obviously Wayne County and Oakland County. So, I think, again, we would entertain and have a conversation with a provider, particularly a pediatric provider in that county if it's in the middle of the state there. But more importantly, again, engagement's key, and again, being in the network, if most of our population is located in southeast Michigan and you're in mid-Michigan, you're not going to get much opportunity. So, but I'm always willing to talk to providers about the value of being in the network.
Thank you. The last question, and we do have to make this brief though, what is the next steps for someone interested in joining?
Well, I think it's, one, you can contact me,
Okay.
We'll get the contact information out. But again, within your geographical areas, we have strong clinically integrated networks. So if you contact me, I will give you a little bit more one-on-one with regard to that. But more importantly, I'll then share that information with our clinically integrated network team. Again, one located here in South Michigan, if you're on the west side or you're in another county, make sure you get the right connections. So certainly open to having further discussions, not only about joining the networks, but if you just want information about understanding what they are and what things you can be doing in your practices to improve your opportunity within any clinically integrated network, I'd be more than happy to talk to you.
Oh, wonderful. We are out of time. Thank you again, Ron. We have a lot of questions left. Just want to tell everybody that we will get these questions answered by Ron and get them sent out to everyone as well. So thank you, everybody, for participating. We truly appreciate it.
Thanks.